Good morning, everyone. Everyone can hear me? Okay. So we heard a lot of good talks about the knee, the ankle, the hip, and the hand and wrist. And as a hand, wrist, and elbow surgeon, I have to say that I think the elbows... Can't hear me? So I just wanted to say that, we've heard a lot of good talks from the ankle, the knee, the hip, and I think the elbow has really the uncharted territory of orthopedics, and there's a lot of things that we don't understand about it. It's a complex joint. And I'll talk today about 3 major injuries that athletes have. And we'll start with the first of these conditions, tennis elbow, which is very common and a misnomer, but I'll talk more about that. Ulnar collateral ligament injuries, which affect the medial side of the elbow. And finally, one of my favorite topics, which is distal bicep ruptures. And for better or for worse, this is not my arm that you see over here. So tennis elbow, it's a misnomer because tennis players get them, but also non-tennis players get this disease. And another term for it is lateral epicondylitis, but even that is not a great term for it since itis means inflammation, and it's not necessarily an inflammation of the tendon. So we think of it as a tendinosis of the extensor carpi radialis brevis, or the ECRB tendon. Those that are 35 to 55 years old usually get this disease, and it is usually the dominant arm, and women and men get it at about the same rate. The symptoms that patients feel are typically around the lateral epicondyle, which is shown here, and oftentimes just distal to it, where you see this red spot, and that's really where the diseased tissue is, the diseased ECRB tendon. So if we think about the anatomy and the pathophysiology of the elbow, this is looking at the lateral side. There are many tendons that originate from the lateral epicondyle here. Many of these are powering the wrist in extension, and the one that is most affected in tennis elbow is the ECRB, and you can see that it's fairly confluent with the EDC, which stands for the extensor digitorum communis, and that allows your fingers to extend. Dr. Nerschel was the one who first coined the term angiofibroblastic tendinosis, and that's what we think of as what is happening with the tendon. And when we have surgery for this condition, we often find that the tendon isn't its usual bright, white, shiny color, but in fact it's grayish, it's edematous, it's friable. And the disease is actually a disorder of the collagen fibers within the tendon, so it's very disorganized. And we think of it as also mucoid degeneration. So if we take a section of this tissue and look at it underneath the microscope, it can look like this, and this is what we just termed the angiofibroblastic changes. And the reason why we think this happens is a susceptible individual has repetitive microtrauma for whatever reason, if it's tennis or any other sport or any other injury that causes repetitive use of the arm, and that leads to that tendinosis that we see. More than not, it often resolves spontaneously, so up to 40 to 90% of the time, it can actually resolve without any treatment at all. And there have been very good studies, meta-analyses of all the world's literature looking at what if you don't do anything, which is no treatment versus injections versus non-operative treatment and versus surgery. And more than not, they all resolve spontaneously. But there are those patients that need treatment, that 10% or sometimes 60% of patients, and for that we first start thinking about non-surgical options, which include bracing, and the counterforce brace is seen here on the top right over here. We also think about wrist splints, physical therapy, and injections, and Dr. Kowalski talked about PRP, and Dr. Green also did too. So, these are not necessarily very proven techniques, but for some people they do show some benefit. For those that don't do any better with non-surgical options after 1 year, we think about surgery, and there are many different options for surgery. One of the most common ones is arthroscopic debridement, so using small cameras we enter the joint, and you can see here that we're inside the joint using the camera, and this is the capitellum, part of the humerus bone, and also the radial head, and the tendon that has been resected or debrided is shown here, the ECRB tendon. I'll show you a few videos of how this is done. This is an arthroscopy. The needle is entering from the lateral side of the elbow, and we're using it just to make sure that the port or the portal is a good position for addressing that tendon. And here we're just taking a knife percutaneously to open the capsule. So we're looking from the medial side of the elbow towards the lateral side. and we're addressing that capsule so that we can open it and see the tendon that's just superficial to that. So using our shaver now, we've entered the joint and we're starting to take down some of that capsule, and you'll see just behind that capsule is going to be the ECRB tendon. And once the capsule is addressed, we can address that tendon here and start to resect or debride that portion. So there are other ways of addressing this. This is a video that we published in this recent hand surgery meeting this year, some of the work that I did in my fellowship. And I'll just show you a few parts of this video, but it's a very easy procedure that can actually be done in the office for those patients that have had symptoms for over a year. You don't need too much equipment. It's very fast, it's simple, and it is safe. Typically, the way we do this is we mark out our landmarks and we draw, this is the line that shows the lateral epicondyle and what we think of as the dividing the safe region versus the non-safe region. And we take a knife and percutaneously are able to actually make a tenotomy of the ligament, of the tendon in a safe way to avoid the ligament. So you can see here that it's a very small incision and it doesn't require very much in terms of the actual procedure, and it's very fast. So this is just one other option. So now we'll move on to the second topic, which is ulnar collateral ligament injury. And really in the literature, it's become an epidemic, and amongst athletes, it's thought of as an injury that's very common. It was first termed Tommy John surgery when Dr. Jobe performed the reconstruction on Tommy John. And you can see here on the right that it's a surgery that's been very popularized and is even published on the internet. So 3 myths about the UCL or the MCL of the elbow. We'll start with number 3. Throwing curved balls at an early age causes this type of injury. Number 2, prophylactic UCL reconstruction can enhance performance. And finally, pitch counts don't correlate with UCL injury. And over time, we've actually proven that each of these is false. So curved balls really are not the reason why you have UCL injuries. Having a UCL reconstruction or a Tommy John construction really doesn't enhance your performance. And finally, pitch counts are really key to the reason why you have injuries to this ligament. This is a familiar diagram that Dr. Kowalski showed, but when we're talking about throwing, there are 2 main areas that put the arm or the elbow at risk. That's the late cocking phase and the acceleration phase. And it's really during this time that the elbow goes under a tremendous amount of force and speed. It undergoes about 3,000 degrees per second of rotation, and that puts, in elite pitchers, almost 120 newtons of force right in that ligament. And that's why you can get micro tears or attenuations and other injuries. The UCL, if we look at the anatomy, is fairly complex, but the parts that matter are the anterior band and the posterior band. And it's really the anterior and posterior bands that restrain the arm when you're putting that amount of force in the late cocking phase and the acceleration phase. There are different ways to test this ligament. We look for tenderness. We also have different maneuvers we can do to stress that ligament. The valgus stress test, something called the milking maneuver, where we place the elbow in valgus and we pull on the thumb, and also the moving valgus stress test, which can also put load on that ligament. But in general, we always combine that test with an MRI. And the MRI, as you can see here on the right, shows that the ligament, in this case, has been torn off of the ulna over here, where this spot shows a joint fluid going through. If you have a chronic problem of valgus laxity or laxity of that ligament, you can develop some arthritis in the back of the elbow. And this diagram just shows that over time, we look for these changes as well. And during arthroscopy, these arthritis type changes can and should be addressed at the same time. So again, there are several non-surgical treatment options. For those that only have partial tears, we stop them from throwing for 6 weeks. And we start physical therapy and a gradual throwing program. And over time, those partial tears often heal by themselves and don't need any surgery. PRP is also an option, and we think of it as a way to help speed up the healing of that ligament. But really, prevention is the most key way to avoid this injury. And the basic idea of this slide is really just limiting the number of pitches. And for those who are prepubescent to avoid any breaking type pitches or curveballs or sliders, and then really addressing the proper pitching mechanics early on and making sure that they have not just good elbow conditioning, but also year-round physical conditioning. The surgical treatment, there are many different methods, but essentially we take a reconstruction of the ligament by using a tendon from the arm, the palmaris longus, and making the ligament in its usual anatomic position through a variety of different ways. Outcomes have been really looked at very carefully over the past few years, since elite athletes often have this injury and this surgery. And reconstructions in general range widely in terms of outcome. Anywhere from 67 to 90% return to the same level or higher level of play. So for those who do well, they actually do quite well. But there are complications to the surgery to think about, and including ulnar nerve problems, stiffness in the elbow, and also heterotopic ossification or abnormal bone growth after the surgery. So we'll move on to the final topic, which is about distal bicep ruptures. And this is fairly common. It happens in about 1.2 in 100,000 people, over 40 years old, mostly men, in the dominant side, and oftentimes in people who smoke. There are two heads of the biceps, and they start from the shoulder and they insert down into the elbow along the radial tuberosity. There is a long head and a short head, and there have been many anatomical studies. And the question is really looking at what weight or what force is necessary to hold the elbow at that degree of flexion of 90 degrees. What do you need? And you need about 50 newtons to hold your arm up at 90 degrees. And it takes about 200 newtons to rupture that ligament off of the tuberosity. On exam, when we look for this injury, there are different ways. First of all, you'll have a Popeye deformity. So that muscle is bunched up on the top of your arm. You'll have some bruising around the medial side. And instead of what we often think of as loss of flexion strength, the actual key loss of strength is weakness and supination. So they have up to 60% loss of strength with supinating. And this is called a hook test, and you can see here that we actually can use that hanger to hook the distal biceps to test to see if it's there. We don't usually do this in the office. So MRI is, again, our imaging choice, and what we see here is the biceps. This is a coronal plane view of the elbow. So the biceps tendon is coming down here, it's black, and then it curls on itself, and this is the typical view, and here's a diagram of the drawing, but oftentimes once that tendon ruptures, it curls back on itself and kind of ends up way up here in the arm. And you can see it's avulsed. There are many different ways to fix it. We have tried bone tunnels in the past, putting suture anchors into the tuberosity, and finally intraosseous screws and cortical buttons. And I would say the majority of surgeons these days are using the cortical button technique. And the reason why we do that is because there have been studies looking at how strong each of these repairs are. The bone tunnel, the suture anchor, and the intraosseous screws are all around 200 or 300 newtons of ultimate strength. And the cortical button is far superior in terms of its strength, which is about 440 newtons. But what you'll see is if you've had a repair of any of these types, it's way above what you need to use your arm. So all of these have been used in the past. And finally, I'll show you that I did some research on this topic in my fellowship, but I'll just show you a few brief slides. This research was based on the idea that if you put the incision for this surgery in the wrong place, you're going to have problems with the surgery. And the reason why I wanted to do this research is trying to figure out the exact location of where the incision for this surgery should be. So we took a bunch of x-rays and measured exactly where the tuberosity or the location of the insertion of the biceps is, and we tried to figure out how best to identify where to make your incision. So after doing a bunch of measurements and some fancy statistics, we ended up finding that we can create a formula based on a patient's BMI, their height, and their sex, and predict within 1 or 2 millimeters of where you should make the incision so that you can perform the surgery in a safe way. And we ended up making a chart, much like a growth chart, that you can bring into the operating room and figure out, say, for like a 6 foot male who weighs about 175, it has to be about 70 millimeters away from a certain bony landmark. And we also proved it in several cadavers, blindly aiming based on our formula where the tuberosity is, and it was very accurate, within 1 or 2 millimeters. So that's it. Thank you.